I feel I should issue a sort of health warning before I start this, because I want to talk about innovation, but I'm not going to mention technology. I want to talk about two things that we've been doing. We're leading an EU FP7 project on innovation in Europe, where we do discuss technology. But within that project, we have a strong module on what we call social innovation, which doesn't involve technology. And I want to suggest that this is part of the future of radical new models of healthcare in very deprived areas. Very quickly, I want to share with you some new data that's coming out of the census that I'm doing with my GIS colleagues in the School of Planning, which I still think, even though I've known them for years, and you know something that's still pretty shocking. Then I want to show you how social innovation can play a role in healthcare in deprived areas. Let's think about, let's say, the Valleys sub-region, for example, and then I want to try to tie this in with some Cardiff University's new engagement projects. I still find this league table pretty shocking. Let me add a couple of caveats right away. There's been no age gender standardisation done in this yet, but we don't expect the league table to change very much. Blackpool will probably drop out for obvious reasons, given the bias in their population. But pretty much this league table will stay the same. It's worth saying that in the interwar period, in the 1930s, there were 4 industrial depressed regions in the United Kingdom. South Wales is now the only one that remains of those regions. And it's the only big industrial region that is officially classified in European terms, quote, as a less developed region. There's been a deep developmental failure in South Wales over the last 50 years. And I think that public health league tables is the most shocking of all. More shocking than the education tables, more shocking than the economic activity tables and the unemployment tables. Public health is where the developmental failure shows up worst. So, social innovation. There are new models of innovation emerging around the world. Some of them refer to things that Lars talked about. But by and large, they're emerging to help us to think about how we address the societal challenges of climate change, renewable energy, public health and aging well. What's unique about all these challenges is that they can't be solved in the traditional way that we've thought about innovation. In other words, we need to harness the role of the consumer, the user, the citizen, to help us to innovate. Companies and technologies, which have been the frame of our innovation frames in the past, can't help us to solve these problems. Therefore, we need to mobilise users and citizens as well. What does social innovation mean? Very simply, it refers to where the goals and the values of the activity, the venture, the enterprise, whatever, are social, defined in terms of social value, rather than in terms of private property. Welsh Water would be a good example of the kind of social innovation that I'm talking about. It's the largest social enterprise in the Welsh economy, for example. But social innovation also highlights the role of users and consumers to change deeply embedded norms, behaviours and habits. And when we think of healthcare change, we usually think about behavioural change as something that applies to and is confined to target populations, poor people in poor health. We often don't use that phrase, behavioural change, to refer to ourselves, whether we're academics, clinicians, or managers. And yet some of the biggest challenges, some of the biggest barriers in terms of integrated healthcare lie in the professions. Integrated healthcare, the biggest challenges are not in terms of merging organisations, which we've often thought of in terms of Wales, but it's breaking down the professional barriers within the professions, the knowledge barriers, because ultimately integration means the integration of services and professions, not just organisations. So behavioural change in this way of framing the issues involves professions as well as target populations. what we sometimes globally refer to as co-production, for example. In social sciences, one of the big debates around the world is whether poor people are doomed to remain in poor health. Or can poor people, despite their income, for example, enjoy good health? This is one of the big debates. And yet, the stereotype of deprived communities is, as I think I've put it here, largely of feckless people who are somehow the powerless victims of circumstance. That's generally the stereotype in the United Kingdom. The opposite of these people, of course, are hard-working families, which is the mantra in Westminster today. And yet, research projects that have been done over the last 12 years at Cardiff University has challenged this view, has shattered this stereotype, if you like. I'm thinking of the SHARP programme, over 10 years old, particularly the Triangle project, which looked at Gurnos, Grangetown, and Ystrad, and some of the researchers in those projects are here this evening and can talk for themselves. The real value, it seems to be, as a healthcare model of some of these research projects is that they aim to mobilise the resources of poor communities, so that researchers were working with communities rather than simply on communities. There's a world of difference in those research models and in terms of those innovation models when we flip from working on communities to trying to work with communities. And this is what community healthcare really means, it seems to me. In terms of Cardiff University's own engagement projects, my job as Dean of Engagement is working on the Vice-Chancellor's 4 or 5 key engagement projects, one of which is Healthy People, Healthy Places, which will be working in Merthyr, we'll be working in Grangetown, for example. But our engagement in poor, deprived communities reaches back a long time. I'm thinking of the Caffini cohort study, a world-famous study of engagement. I'm thinking of the work, the collaborations that have gone on between my own school, CPlan, School of Planning, and people in the School of Medicine. John Gallagher has worked with Chris Webster and thinking about new ways of putting planning and epidemiology together, thinking about the role of urban morphologies and the role that they play in shaping health outcomes, for example. I think one of the most useful alliances of all in the future going forward is to marry together work in the School of Medicine with work going on in the School of Social Sciences and School of Planning, for example. I've mentioned the SHARP project. The Keir Hardie, some of you will know the Keir Hardie University Health Park, which is to be opened later this month with a health minister. The work of Chris Jones, the work of Mansell Aylward, and as many people have worked hard to try to promote a model of integrated healthcare in the valleys. This is another beacon, I guess, of Cardiff University's engagement strategy, and a lot will ride on this centre, how local people interact with it, and whether the centre can, as I said earlier, can learn to work with local communities rather than simply on them. In my own work, for example, on healthy diets, how do we secure healthy diets, particularly in poor communities? For the last 10 years, we've worked on public food provisioning around the world, looking particularly at school food provisioning in Europe, in Africa, in North America. And I'm delighted to say that we won the ESRC's Outstanding Impact on Public Policy last year, for the first year that it was ever introduced, for our impact on the school food system around the world. So on the basis of that, we're now working on healthy cities. What can cities do to promote healthier outcomes using the food system? And I leave you with this final thought, really. When communities try to promote healthier outcomes through, let's say, healthier diets, they trigger enormous kickback from some of the most powerful forces in the corporate world. Let me just give you one example of what we're dealing with our partners in New York City. This is a full-page advert taken out by Consumer Freedom Association, the very people that persuaded us that tobacco was good for us. They're now trying to persuade us that any regulation of fast food will incur the wrath of very, very bad adverts. They've dressed Mayor Bloomberg is no longer the mayor of New York, as you know, but when he was the mayor, he tried to regulate soda sizes, sugar drinks. He tried to put a cap on them. And Consumer Freedom took out this page, a full page in the New York Times. Now, I simply put this up because the barriers to healthy eating don't just reside in the breast of an individual or in a poor community, be it Gurnos or Penrhys or whatever. There are deep systemic barriers to healthy eating, to social innovation, if you like, because large parts of the corporate food system have a strong vested interest in not seeing social innovation in terms of healthy eating, as one example. But through this research, I hope that Cardiff University can engage in new ways in deprived communities, and that will involve new behaviour within the academy, from ourselves in this room, different schools beginning to work together across colleges, like, for example, the School of Planning, working with the School of Medicine. Thank you very much.